Well, welcome back, you guys. Today we'll be going through the anatomy of the stomach. So, of course, the function of the stomach is to grind up your food into smaller pieces and dissolve the proteins and the carbohydrates in order for the intestines to absorb the nutrients. But besides the storing and the grinding, it also makes something called chyme. So, chyme is a mixture of gastric secretions and zymogens that will either activate in the stomach in the presence of the hydrochloric acid or in the duodenum when it is starting to be mixed with the bile. So, besides making the chyme, the stomach is also responsible for controlling the rate of delivery of the chyme to the small intestines, because the food doesn't go into the small intestine in like one large go. It comes into the small intestines in portions. So after a meal, it'll grind up a little bit. Let's say it's kind of like squeezing icing out of like a piping bag, so like a little bit will come out through the pyloric sphincter. So just to go over the topography a little bit, stomach is mostly in these regions, the epigastric and the left hypochondriac region, and a little bit in the left lumbar region and the umbilical region. In anatomy lab in cadaveric studies, we use the 9 abdominal pelvic regions, but in a clinical setting, we really only use the quadrants. So the stomach would be in the left upper quadrant and the right upper quadrant. So the entrance of the esophagus to the cardiac orifice is the official entrance into the stomach, and it occurs at a place that has a certain distinctive zigzaggy layer where the epithelium of the esophagus changes very suddenly to the gastric mucosa, and that is at the Z line, and that is around T11. The exit of the stomach is through the pyloric orifice, and that is at L1. So another important thing to know is that the cardio-esophageal junction is about 3 fingers breadths below and about left from the xephosternal junction, while the pylorus is in the transpyloric plane. So this is actually the transpyloric plane. The cardioesophageal junction is an important landmark because that is where the orifice is, so the entrance and the official start of the stomach. So Lab's triangle is at the transpyloric plane, the left margin of the 9th ribs on the left, of course, and the costal arches along with the liver on the right. And it's important because this is where the stomach is in contact with the abdominal wall, it like presses right up against it. And that's important for us as clinicians because this is where a G-tube will be inserted. So G-tube will go through the fascia and the muscle and the adipose tissue of the abdomen into the stomach itself, and that is where patients who suffer from like dysphagia or esophageal strictures will be able to get food. So when the stomach is filling, it like protrudes outwards and downwards. So sometimes if it's a little bit overly filled, the stomach will dip down in front of the transverse mesocolon. If the colon is distended, so if you are bloated and feeling kind of gross, the stomach will enlarge and press upwards into the liver and the diaphragm. That's why when you eat too much, you feel out of breath. So anteriorly, it's bounded by the anterior wall, of course, the left costal margins, the diaphragm, and the left lobe of the liver. Superiorly, it's going to be bounded by the diaphragm. Posteriorly, it's going to be the lesser omental sac, the pancreas, which is pretty important, the transverse mesocolon, Sometimes, like I said, it dips in front when it's full, but like in reality, it kind of like rests on top of the transverse mesocolon, and the transverse mesocolon, the pancreas, and the transverse colon itself makes something called the gastric bed. An important thing to know is that behind the stomach is the kidney, the hilum of the kidney, along with the suprarenal gland. The spleen is behind it, along with the splenic artery, and then the ureter. So up here is the fundus, usually filled with gas, and the body. It's from the cardia all the way down here to the insula angularis, also known as the angular arch. It's just a fancy word saying that it's permanently an arch. It sounds kind of silly, but actually it's a pretty useful landmark to identify when trying to perform any kind of gastric surgery, because if any of the parts are distended and, or if there is a foreign object in the stomach, and the stomach can be kind of like in weird shapes, the angular notch will always be there. So the pyloric antrum is going to be from the insula angularis to the pylorus itself. And the pylorus is going to be far thicker, as you can see here. Here's the pylorus. Here's the pyloric part of the stomach. It's much thicker. It's made out of longitudinal fibers as long as circular fibers and oblique fibers. And just like, it's just more robust because this does control the entrance of food into the duodenum. The smooth muscle, as you can see here, there's the circular, the longitudinal, and the oblique layers. This allows the stomach to stretch quite a bit and have the elasticity, so after you've eaten a fairly large meal, it can snap back into its original size. So why is the pyloric sphincter so important? Why is it important not to dump all the food into the duodenum? So the duodenum doesn't have as a robust layers of smooth muscle, so too much will rupture the duodenum. As you can see here, there's all these, and then the duodenum. Okay, so there's two sphincters, and the first one is going to be the esophageal, or lower esophageal sphincter, and this is going to be reinforced by the right diaphragmatic crus, and that creates the high pressure zone. Why is that important? The intra-abdominal pressure is positive, while the intrathoracic pressure is negative. Why is that important, right? Well, we need the intrathoracic pressure to be negative because that's where your lungs are. That's how we breathe. There has to be negative pressure in order for the air to enter. The intra-abdominal pressure is positive in order to increase the negative pressure here, and also to lift any heavy objects, really. So, whenever you lift something heavy and sometimes you just force out a breath, that's how we are able to recruit a little bit more muscle fibers and to brace the core in order to lift anything. And that's possible because of this sphincter. So in the stomach, there's these things called clasp fibers, and those will control the tone of the sphincters. They are affected in women who are pregnant. These will relax a little bit and cause acid reflux. So the folds of the gastric mucosa, the lower esophageal mucosa of the gastric fold, and the adipose tissue will make the seal. So the pyloric orifice, like I said, is made of a thick circular muscular layer, but it also has things like the connective tissue septa invaginating in. So here you go, increasing pressure, and in the increased BMI will cause an increased pressure and weakening of the sphincter, causing reflux to occur. So inside the stomach is these squiggly folds of mucosa are called rugae, and they are there in order for the stomach to be able to expand even more. So how much can the stomach expand, right? And I'm talking about a generally healthy-ish individual. So for the average American, our stomach can actually expand 4 to 5 times its normal size. in somebody who is morbidly obese, and by morbid I mean like over 50% BMI, their stomach can expand almost like 7 to 10 times. In the gastric canal, it's also called the Magenstrasse, and the lesser fundus, the Ruge, is linear and parallel and a lot more regular in nature, as you can see here. See, it's linear, it's regular, and over here they're just kind of going wild. Why is that, right? It's so whenever you drink liquids, it can just travel down this route and is just directed straight into the duodenum. Okay, so the stomach is considered intraperitoneal, and then there are all these ligaments connecting it to all the surrounding structures. So the hepatogastric ligament, hepato, liver, gastric, stomach. So this connects it to the stomach, forms the lesser omentum. Gastrosplenic makes the splenic ligament, that omentum that connects to the hilum. The gastrophrenic ligament will connect to the diaphragm, of course. The gastrocolic ligament will connect to the transverse colon, and then there's going to be the gastropancreatic and the pyloroppancreatic ligament. So the stomach is actually held quite well in place. So the lesser curve of the stomach is really supplied by the left gastric and the right gastric arteries. The right artery will come from the proper hepatic artery, and the left gastric artery will arise from the celiac trunk. So the left is going to be the largest of all of the vessels that supply the stomach. And the right curves, it's going to be supplied by the right and the left gastroepiploic artery. And the left gastroepiploic artery is a branch of the splenic artery. As you can see, it also supplies spleen, and it kind of curves in the back. The splenic artery curves in the back to drain into, it curves in the back and is also supplied by the aorta. So the right is the branch of the gastroduodenum artery, and that supplies the stomach, the duodenum, and the omentum. So there are some important anastomoses. The right gastric anastomosis will form this arcade, which is kind of like loops. Loopy kind of anastomosis. Let's go back. So, this is not a very good picture, but kind of like loops like this. Those are kind of considered arcades. With the left gastric artery, the right epiploic will anastomose, of course, with the left, and then both will eventually unite. And additionally, the pyloric artery will pierce the duodenal wall. That will supply the submucosa and the esophageal sphincter, and that will anastomose with the submucosa artery. And then this is a really important clinical correlation right here. The esophagus arteries will anastomose with the vessels supplying the fundus. So gastric vein will drain the fundus and some of the greater curve. The left gastroepiploic will drain the anterior and posterior body, along with the greater omentum, and then it runs along the curve between the gastrocolic omentum into the splenic vein. The short gastric vein will drain the fundus, and the left gastric vein will drain the upper body, and then kind of like curves around, drain the fundus as well. And it curves behind the lesser omental sac. And importantly, all of them will eventually drain into the portal vein. But in a decent amount of the population, about like a third of the population, it will also drain into the splenic vein. Okay, so this is the important clinical correlation that I was speaking about. Varices. So the esophageal vein and the left gastric vein is going to anastomose in the abdominal region, while in the lower thoracic vein, they're going to drain into both the azygous and the hemiazygous vein. So in these veins, bidirectional flow is possible in order to accommodate the pressure changes. Remember, the intrathoracic is going to be negative, and the intra-abdominal is going to be positive. Why do they change so much? How often does the pressure change? well, anytime you take a breath, really, anytime you want to force out air to scream, anytime you sneeze, that will raise the pressure or decrease the pressure, and the flow will accommodate for it, or otherwise else you would pass out. So in a liver disease or portal vein thrombosis, to accommodate these conditions, the body will dilate these anastomoses, leading to something called caput medusae in liver disease. And that's when the varices are overly dilated. In addition, portal hypertension will recanalize an embryonic vessel between the portal and the systemic system. Which one is that? It's the ligamentum teres. And why is that problematic? Well, these veins aren't supposed to take that much blood, and when too much blood fills them, the valves will become incompetent. Blood will stay in and stay in the sections, and those will like kind of bulge in an aneurysm, and in some cases they might like rupture. A lot of the times they are very uncomfortable. Okay, so the lymphatics follow certain routes. The first area will drain along the right and left gastric vessels to the aortic nodes, and then the second area, it's on the outside, those will go to the subpyloric nodes, and then the third area will go into the suprapancreatic nodes, and then all of that eventually will drain to the aortic nodes, and then from there into the internal vena cava. Oh, I'm sorry, not into the internal vena cava. It'll go into the thoracic duct. Sorry. So there are tons and tons and tons of nodes around the stomach, and that is problematic because any stomach cancer, it can erode through all the walls of the stomach and go into either like the lymph nodes or the pancreas. And as you can see here, once you get into the lymph nodes, it's almost game over because it goes into the thoracic duct, and thoracic duct goes everywhere. So the stomach is innervated mostly by the splanchnic nerve and the celiac plexus in the sympathetic division, and that controls the pain, the constriction, and the motility of the stomach. On the parasympathetic, it's going to be supplied by the vagus nerve, which has a role in relaxation, emptying, and secretomotor functions. So it will secrete like mucus. There is pain due to the stretching or spasms of the smooth muscle, and it's not very well defined kind of pain. It's like dull, aching, kind of non-focal pain, and usually that refers to the epigastrum. Okay, so this is a normal X-ray of a normal stomach. You can't see anything, of course not. So in order to see anything, there has to be a contrast, and usually barium sulfate is given in a meal, and then lights up on the X-ray, and you are able to see it. Gastroscopy is going to be an endoscope inserted into the stomach, and then that is used to literally look at the mucosa and to identify any kind of like ulcers or perhaps any kind of like infections. This is not a fun procedure, much rather the barium meal, because you are awake for this procedure. You have to have air pumped into the stomach in order to unfold some of the rugae, and unfortunately, when the endoscope touches the back of the pharynx, it will trigger the gagging reflex. So, nasogastric intubation is really performed to empty the stomach in adults in order to decompress it during intestinal obstruction, or to get like gastric secretion samples. In babies, it's used to feed usually like premature babies, and you have to be very careful not to enter the larynx because you can perforate it. Nosebleeds and perforation of the stomach or the esophagus is unfortunately kind of common. And as you can see here, this is kind of like where the nasogastric feeding tube will be if the stomach is still functioning. But if the stomach is not functioning, you might have to go all the way into the nasojejunal feeding. Okay, So the majority of gastric ulcer causes is an H. pylori infection, and that is usually in the lesser curvature at the angularis, so at that notch. Why there? It's because a lot of the alkaline secretion occurs, and that makes a nicer environment for the Helicobacter pylori. Sorry, I can never remember these full names, but H. pylori is an interesting bug because it can't really survive in a low pH, so it will bury itself into the mucosa and secrete like an alkaline substance, making that part of the stomach alkaline, which reacts violently with a hydrochloric acid, and then that eats away at the exposed mucosa because it's alkaline. And this reaction will cause like a hole to be eaten into the mucosa, and in bad cases, it can invade all the layers of the stomach, and then all the way into the peritoneum and into the neighboring structures. So it can invade the liver, the spleen, and perforate the stomach itself. And then that's problematic because that can cause the peritonitis once the stomach contents leak out. And posteriorly, if it keeps eroding, it can actually erode the splenic artery. And of course, the splenic artery is a pretty big artery, and this is unfortunately fatal. In the anterior case, if it wants to go forward, it can cause a bleed from the left gastric artery, which is less fatal but still concerning nonetheless. Okay, so gastric cancer is pretty terrible because metastasis is deadly. Remember when we covered all of the lymph nodes and how many there were and what they kind of like flowed into? That's why it's a problem. So use the gastroscopy to see if there's any kind of like suspicious growth there. These are suspicious because they're bleeding and they're irregular, like how much like fresh blood there is. In order to treat it, you have to do a total gastrectomy. So not only do you remove the stomach, you also remove the first part of the duodenum, along with part of the esophagus, the spleen, the pancreas, and all the lymph nodes you can possibly get. Sometimes a partial resection is used for an intractable peptic ulcer. And usually, since it's usually at the area of the angularis, part of the pylorus is removed, which in itself causes problems because now there is no sphincter. So what do? There is something called like either like a Whipple procedure or a Ruge procedure where the esophagus is basically like linked to uh, the small intestine directly, or sometimes a bit of the stomach is preserved, but it's going to be artificially like making an artificial anastomosis between the stomach and the esophagus into the small intestine directly, kind of like bypassing duodenum and everything. Okay, so the afferent loop syndrome is in patients where a gastrectomy has been done, and the problem is that normally the small intestine doesn't always contract. Like it's not like the stomach always contracting. It's peristaltic movements, and it contracts in slow waves, and it can take some time. So the stomach takes about 4 hours to empty completely, while the small intestine takes about 4 days to empty. So this can be problematic because in these artificial anastomosis, the food can stay into the afferent loop and then reflux back into the stomach. As you can hear, and staying in the loop will cause, of course, rot and then infection. Refluxing into the stomach will reflux into the esophagus, causing GERD or acid reflux. So how do we treat that? We make an anastomosis with the afferent loop instead, so the food can just go straight through. Okay, so dumping cyst syndrome occurs after resection of the stomach, and that's because, once again, excuse me, there's not going to be any pylorus and no the constrictor control in order to allow the chyme to go in an orderly fashion. And the meal from the stomach or the esophagus, depending on how much was resected, goes directly into the small intestines. And um, like I was saying in the last slide, intestines don't contract very often. Um, so it's not ready for the high osmolarity of the food. What's the problem with that? The liquid will leave the body in order to, travel down the concentration gradient, and by doing that, the extracellular fluid volume will decrease in the body. And in severe cases, it will lead to hypotension and tachycardia. And there's going to be an orthostatic collapse right after eating because, like, the minute food has been squeezed out of your esophagus and into the duodenum, um, and all the water is going to be like drawn out of the body, and blood pressure is going to drop. So fluid goes to the food, there's going to be more diarrhea, there's loss of water, there's no absorption of the food itself because the stomach wasn't there to like really grind it up into smaller and more manageable pieces. And without the smaller pieces, there's not going to be a lot of surface area for the stomach to really, for the small intestines to really absorb anything. So, how do we treat this? It's really just a management case. You have to prepare the food with a lot of water, so soups and stews and smoothies and the like. And they have to consume things in like small sections. So, instead of having like 3 square meals a day, it would be like having 6 or 7, like snacks. So, the gastric sleeve is really it's really mostly used to treat obesity. Um, and there's a bunch of varieties. So in some, they remove part of the stomach, and then with the artificial like gastric pouch, it just is linked directly into the jejunum, and then and the duodenum is going to be bypassed, and then goes right into the small intestines. This is the Ruge gastric bypass procedure. Sometimes they create more artificial folds in order for the stomach to take longer to grind up the food and try to absorb it. So you're gonna make some artificial rugae. And in the vertical sleeve gastrectomy, it's going to be just like removing this part of the stomach in order to make the stomach smaller. And all of these are really just to control how much food can come in and how to feel full faster and or longer. The vagotomy is going to be resection of the vagus nerves, and there's 3 different types, but the most common one is going to be the highly selective. So you do it usually when the gastric ulcer is almost permanent and you can't really treat it no matter what. And it's not as often, it's not as popular as it is, as it used to be, because of the advent of all these like over-the-counter anti-reflux medication. So the problem is that you have to be pretty careful not to resect the trunks, but in some cases the truncal resection is done. There are several cons to these procedures. So, in a truncal vagotomy, it stops the solid emptying and the secretion of acid. So, it's going to slow down the emptying and secretion of acid. So, food is going to sit in the stomach longer. So, of course, you're going to feel full slower, and it's going to increase the emptying of liquids. A bit problematic because then you're more susceptible to being dehydrated. This requires an extra stent or a drain in order for the solid food to drain out. The next procedure, the selective or the total gastric vagotomy, is used to suppress the acid secretion, and it also requires a stent or a drain. Highly selective will stop the nerve stimulation to the stomach but still allow for the peristalsis because it really is more focused to stop the impulse to the parietal cells. Okay, so that's it for now. Thank you for your attention and good luck studying.